So how to optimize the choice of monofocal IOLs? Basically, aspheric versus non-aspheric IOLs. Uh, it's not moving forward. Okay, as we all know, in the total eye aberration, we have corneal and internal aberration, and measuring just corneal aberration without lens or total aberration is of questionable value. And aberration can be described quantitatively using these Zernike polynomial, and higher order aberration accounts for around 15 to 20% of total ocular aberration. And the clinically relevant aberrations are coma and spherical aberrations. And the lower aberration, as we know, are defocus and astigmatism in the form of myopia, hyperopia, or astigmatism. And they are correctable in many ways, and they are accountable for 80 to 90% optical defect. And higher order aberration, the commonest ones are secondary astigmatism, coma, and spherical aberration, and they account for 10 to 20% of the optical defects. And as we all know, spherical aberration could be either positive or negative spherical aberration. This cartoon shows the wavefront of a positive and negative spherical aberration. And as we all know, spherical and defocus aberration are the only aberrations of centered optical system, and these are the only two aberrations which has been targeted by aspheric IOL. But of late, even the coma has been targeted by a few IOLs available in the market. And as we all know, spherical aberration in the human eye is in young age is positive corneal spherical aberration, and the young crystalline lens has a negative spherical aberration, which partly compensate for positive spherical aberration of the cornea. And as the age advances, the spherical aberration of the crystalline lens moves to the positive side, and it no longer compensate for the positive spherical aberration, and the quality of vision goes down. It has an additive effect on the corneal aberration. And if we replace that lens, this is in young age, when the negative aberration neutralizes positive spherical aberration, and you get a very sharp vision. And if this is the two eye of the same patient, in one eye we have put a spherical A negative lens, and here is a plain lens, and you can see the point spread function and cell ratio close to 1, and it is very good. And as we all know, spherical aberration affects the quality of vision, and this is how the spherical aberration changes with age. And this cartoon shows, or the diagram shows, which different type of IOL with different asphericity. As we know, this has a 0.27 micron, this has around 0.2 micron, this is aspheric neutral. And in a post-myopic classic eye, we will like to use a lens with the maximum spherical aberration like amotexness. And in a post-hyperopic eye, we like to use a lens with a negative spherical aberration, which could be a normal non-aspheric lens. And the study has shown that the results of optimal ocular spherical aberration and IOL spherical aberration for 6 millimeter pupil varied widely between eyes, and with defocus of 0 diopter or zero point 0.5 myopia or zero point 0.5 hypermetropia, most eye achieved the best image quality at an ocular spherical aberration of either minus 0.1 to 0, plus 1.1 to plus 0.3, and minus 0.4 to minus 0.2. What does this mean is, if we have a zero defocus, the best spherical aberration in the lens should be to the tune of this much, or the total spherical aberration in the eye should be this much. If we are aiming for myopia, the corneal spherical aberration should be around this much. And this bar diagram again shows that this is for the Technis lens, which has a 0.27 micron of spherical aberration, and we should be choosing a plano target in these cases. And various studies have shown that customized selection of aspheric IOL based on corneal wavefront is feasible and produces favorable result compared with studies of unselected patient population implanted with aspheric IOL. This slide has already been projected by Dr. Chintan, but here I will add on simple thing. If there is a large angle alpha, we should also avoid a aspheric IOL. Either we should use a aspheric neutral or a non-aspheric IOL, because decentration of aspheric IOL also leads to lot of aberration. Now coming to the example, this is the dysfunctional lens display of the patient. As you can see, the cornea is quite good, and the DLI index, we will come into that in the second arc, is just 0.85, and most of the aberration are internal, and he has a grade 3 opacity, and angle alpha is good. So in this case, and the reflection is not reliable, it is in red zone, it's because of the higher order aberration. You can see internal higher aberration are very high. So this is the Chang analysis showing the same thing, very high internal aberration. And in this case, and the angle alpha very within normal limits. So in this case, the corneal aberration is to the tune of 0.39. So in this case, we like to choose an IOL with the high, like 0.27 micron of asphericity. One can choose any IOL, but with asphericity of maximum negativity, and the modulation transfer function is cornea is good, internal is less, and we did a surgery in this case. You can see the internal aberrations have decreased, and even the corneal spherical aberration remains same, but the total spherical aberration reduces to just 0.07, because it neutralizes the corneal spherical aberration. And this is the quality of vision combined after the surgery. And this is the point spread function, as Dr. Amit Gupta highlighted. It has improved drastically after the surgery. And this is another eye. Here you can see the angle alpha is very high in these cases, though it's a sort of taking the error in the picture. So one should be very careful while taking the shots on the eye trace. So if it is too high, one should be avoiding. I'll just another minute. And this is another patient again here. The DLR internal dysfunctional lens index is almost normal, more than 5, and the opacity is also very less. And but the angle alpha is around zero point 0.6. In these cases, one should be avoiding uh, uh, aspheric IOL. Either one should use aspheric neutral or the normal lens. And this is another case with just internal corneal spherical aberration of 0.17. So here you would like to choose no other contraindication, but this is the same, and alpha angle is high. So here you will again like to choose maybe aspheric balanced design IOL from Hoya, which to some extent negates the coma aberration because of the large angle alpha. This is another patient with 0.34 corneal aberration. So here again we like to choose an angle alpha is good. Here you can choose any type of IOL, as the machine also says. You can choose multifocal, toric, or premium IOL with the high negative asphericity. This one patient with the 0.29 corneal aberration here. This is the patient from Dr. Amit's clinic. He has put an eye has. As you can see, the internal aberration have decreased after the removal of the lens, and the total corneal aberration, total eye aberration also has reduced to minimal, and patient has excellent vision post-operatively. So with this, I'll end my talk, and we will invite the next speaker.